Morbidity of Can Dr. Ravikima. Why do I need to know? Increasing curates endocrine abnormalities are a common late effect pre-treatment counseling post-treatment screening. Knowledge of side effects may allow creation of better tolerated regimen. Which endocrine glands are involved? Hypothalamo-pituitary dysfunction, thyroid carcinoma and nodules, parathyroid dysfunction, gonadal dysfunction. Hypothalamo-pituitary axis. Main insult is radiotherapy used in RX of pituitary adenomas, craniopharyngiomas, intracranial tumors, nasopharyngeal carcinoma, all TBI for BMT. Generally GHLH, FSH, ACT, TSH. However, ACT may be lost before LH. FSH. Hypothalamus more sensitive than pituitary. Hypothalamo-pituitary axis. Incidence, extent and onset of deficiencies determined by irradiation, dose, fractionation, age, pre-treatment state. Hypothalamo-pituitary axis. Management. Screen for at least 10 years. Screen growth rate and pubertal development in children. Regular biochemical screening in adults and children receiving high doses. Basal and stimulation tests. RX's replacement. Precocious puberty. 50 Grays to HP axis. Gonadotrophin deficiency less than 50 Grays. Early puberty. Males have higher threshold, reduces time available for GH therapy. Significant psychological sequelae. Regular assessment of pubertal stage +/bone age +/GnRH test. RX, GnRH analogues to delay puberty. Thyroid. Hypothyroidism, Graves' disease, euthyroid, Graves' ophthalmopathy, atypical thyroiditis, thyroid cysts, nodules. Hypothyroidism. XRT for treatment of lymphomas, head and neck cancer, craniospinal irradiation and TBI, usually 30 to 50 Grays. Multiple fractions may be transient plus resolve. Half of cumulative risk in first 5 years. Hypothyroidism. 27 years after irradiation for Hodgkin's disease, 47% were hypothyroid, 2% of the control population. Hancock et al. 1991, Nejm, 325, 595, 605. 10 to 45% following XRT for head and neck cancers, 23 to 73% following TBI, single fraction. 10 to 28% following TBI, multiple fractions. Hypothyroidism. Incidence of hypothyroidism dependent on dose and fractionation. Prior hemithyroidectomy and cervical surgery. Age less. Hypothyroidism. Management. Screen with twice yearly TFD initially and yearly thereafter. More frequent screening if symptomatic. Treat both definite and compensated hypothyroidism. Treatment is thyroxine. Hypothyroidism. A. Graves' disease, 1,677 pints treated with XRT for Hodgkin's. 34 developed Graves' disease, predicted 7.2 to 20.4. Hancock et al. 1991. Nejm, 325, 595, 605. Thyroid dysfunction and medical therapy. Interferon and IL-2 incidence. Autoimmune hypothyroidism, hypothyroidism and thyroiditis. 5-fluoroacyl TT3, TT4 as a result of TBGL asparaginase TT3. Thyroid carcinoma association followed an observation that 928 children with thyroid CAR had received irradiation for thymic enlargement. Meta-analysis of 58,000 patients, XRT field involving thyroid, predominantly childhood therapy. Correlation between XRT dose and risk of thyroid CAR, RR7, thyroid carcinoma. Increased risk observed in thyroid nodules. Pathology. Focal hyperplasia, single or multiple thyroid nodules. Management. T4 to suppress DSA. Parathyroid dysfunction. Increased risk hyperparathyroid. Gonadal dysfunction. XRT. Testis germinal epithelium greater than gonadal dysfunction. XRT. Quicker fall with gonadal dysfunction XRT. Leydig cells more resistant to XRT significant. Gonadal dysfunction XRT. Gonadal dysfunction chemotherapy. Gonadal dysfunction chemotherapy. Cyclophosphamide monotherapy. Gonadal dysfunction chemotherapy. Lymphomas MVPP for hot. Gonadal dysfunction chemotherapy. Test. Gonadal dysfunction Gonadal dysfunction chemotherapy. Transmissible genetic. Gonadal dysfunction XRT. Ovary effects are age and dose dependent. Ovarian dose less than 4. Gonadal dysfunction XRT. Less than 40 years of age. Estimated dose for POP. Gonadal dysfunction XRT. Uterus XRT involving uterus during childhood can result in failure. Gonadal dysfunction chemotherapy. Ovary, Hodgkin's disease MVPP, COPT, CHLVPP 38 to 57%, gonadal dysfunction chemotherapy. Newer regimes, ABVD results vary depending on gonadal dysfunction chemotherapy. Damage dose and age dependent with age permanent. Gonadal dysfunction chemotherapy. Older women smaller pool of oocytes gonadal dysfunction chemotherapy. Protection of gonadal function testes. Gonadal dysfunction chemotherapy. Ovary, cryopreservation.